I think historically we've really divided lung cancer into two major camps, small cell and non-small cell. I think over the past 5 to 6 years, in the non-small cell category, we've demanded that our pathologists tell us whether it's squamous or non-squamous. And particularly in the non-squamous group of patients, we now are interrogating selected patients for EGFR mutations and EML4 ALK translocations and those sorts of things, suggesting that a disease we thought of as two major groups is now being segmented into several different groups, akin to the story in other cancers such as breast cancer. And we know that historically people have made the association between lung cancer and smoking, but we have an increasing number of patients who have never smoked that get this disease. And so you have to ask the question, if you didn't smoke, why did you get this disease? And in that segment, there are a number of oncogenic drivers of the cancer. The advances we've made have been in understanding which therapies are best for which patients and what is driving some patients' cancers that distinguishes them from this broad category of non-small cell. EGFR mutations, I think, are a very nice example of that. And certainly the standard of care for those patients has changed based upon randomized clinical trial data. And part of making sure that more patients get drugs that are effective is using them earlier. And if you integrate them right after your first-line therapy, don't let that drop off from first to second line occur. Then I think the end result is that more patients will get more drugs that work, and I think we now have evidence that that strategy improves overall survival. I think that patients need to be informed about the benefits of therapy and also need to be informed, as I try to do, that even though they may not have a curable disease, they have a treatable disease, and that it's important to get exposure to all your treatment options. They deserve an honest opinion, an optimistic opinion, and the right therapeutic recommendations at the right time to optimize their survival experience. It all really starts from the initial workup and getting the diagnosis right, getting the stage right, and creating a therapeutic plan that's individualized for that particular patient. That was only 15 years ago in which the world was convinced that this was a treatable disease. So when I think about, from that historical perspective, the changes we've made and the gains we've made in a relatively short period of time, of 15 years, to me it's amazing. Not to say that we don't have a long way to go. One is understand that biologically this is a very heterogeneous disease, in that it is not a situation where one size fits all. And secondly, developing better drugs and using the right drugs in the right patients. And that's really the challenge we have in front of us.